Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. To a health policy analyst, biosimilars are to biologics as generics are to branded drugs. So just as the introduction of generic competition dramatically reduces what people pay for drugs, biosimilars place price pressure on biologics, which in the absence of competition can be quite expensive. But the regulatory regimes for biologics and branded drugs are different, and there is ongoing concern that the United States is not experiencing the same potential price benefits from biosimilar introduction as it is from generic drugs. Now, just as with drugs, the decision to use a biosimilar depends on choices that have to be made by patients and prescribers. So what do we know about the relationship between patient and provider characteristics and uptake of biosimilars? That's the topic of today's episode of A Health Podyssey. I'm here with Dongzhe Hong, a postdoctoral research fellow at Brigham and Women's Hospital and Harvard Medical School. Dr. Hong and co-authors published a paper in the August issue of Health Affairs exploring biosimilar use as it relates to patient and provider characteristics. They found important differences along a number of dimensions, which we'll discuss in today's episode. Dr. Hong, welcome to the program.
Hello. Hi, everyone. It's my great pleasure to being here.
So we've talked some about biologics and biosimilars on this program, but I do want to make sure I think people tend to be less familiar with them than they are with sort of generics and drugs that you pick up at the pharmacy. Can you just say a little bit about what a biologic is, what a biosimilar is, and how we should think about the two of those together?
Yeah, of course. So biologic drugs, they are large, complex molecular derived from living cells used to treat various diseases, including cancers, autoimmune disorders, and chronic conditions. Because of their complexity and their living systems used to produce them, so biologic drugs are usually more difficult and costly to manufacture compared to those small molecular drugs. Biosimilar drugs, they are highly similar to already approved brand name biologic drugs in terms of their safety, purity, and efficacy. Although they are not identical to the reference biologic, biosimilars have no clinically meaningful differences and provide the same therapeutic benefits. They are introduced to the market after the patent on the reference biologic expires with the intention of offering less expensive alternative. Specifically, an interchangeable biosimilar is a biosimilar that meets all the criteria for a biosimilar and also demonstrate that it can be substituted for the reference product without any increased risk to the patient. And this typically involves additional switching studies where patients alternative between the biosimilar and the reference products, and which makes less number of those interchangeable biosimilar drugs on the market.
So in that regard, this does sound quite similar to what we think about with branded drugs and generics. You have a patent and you can control the market for a certain amount of time. And when you lose your ability to control the market, the generics come in and they can come in at a lower price. But as I noted at the outset, my understanding is that we don't see biosimilars coming onto the market as fast as we see generic drugs. And I also think there's some sense that in other countries they've been able to do this a little faster. So what do we know about the rate of uptake of biosimilars, given that we know generics can have very positive effects on the prices people pay and affordability?
Yeah. Thanks for this question. And I think like the general sense from you is correct. So different from like the small molecular drugs or the generic drugs, usually the generic drugs gonna take up to 90% of the market share after generic entry in 3 years. But most biologic drugs facing competition had less than 30% biosimilar market share within the first 2 years. And our study found that like the initiation rate, even after like 5 years or 7 years of the biosimilar approval, this in general, like the biosimilar market is still less than 30% in 2022. So, we do see, so in other words, like we do see like a slower uptake of biosimilars in the United States. And I think there are two challenges or two ways of challenges like in getting biosimilars to the patients. One is the getting biosimilar onto the market. So which means first, it is because of the biologic products patent thickets. For example, like biologics are often protected by thickets of patents, which can delay the entry of biosimilars into the market because biosimilar manufacturers must navigate and challenge these patents before launching their products. And biosimilar manufacturers often face extensive litigations from originators' companies as well. And this complexity and cost of patent regulation add to these delays, making it harder for biosimilars to reach the market. And the second thing about this part is that the regulatory hurdles. In other words, the regulatory pathway for biosimilar is more complex than for small molecular generics. It usually requires more extensive and expensive clinical testing compared to generic drugs. And the exclusivity period for brand name biological products is 12 years, which is longer than the brand name small molecular drug, which is 7 years. And then the challenge becomes to the market uptake once biosimilar are available. So in terms of one is lack of interchangeability, as we mentioned before, because this interchangeability status needs more clinical trials to test their whether they can get this or the drug can be granted this designation. And this limits their use as physicians may be reluctant to switch patients from a biologic they are familiar with to a biosimilar. And also, biosimilars are generally, even though they are generally cheaper than their reference biologics, the cost savings are not as significant as those seen with generic small molecular drugs, which means they also relatively expensive compared to the generic drugs. And of course, as we did our study, we found only a few biosimilars are on the market right now compared to the generic drugs versus the brand name drugs. So in other words, even with one or two biosimilars on the market, the market competition may not be sufficient to significantly accelerate adoption rates or lower the cost for the same class of treatments.
So you're describing a set of dynamics, again, that play out with respect to branded and generics, but are things like patent challenges. We see that everywhere, but you've got different timelines, and then the regulatory pathways, you have some of the same issues, but again, the specifics are different. This notion of willingness to prescribe because based on confidence that you'll get the same results seems critical. So that really turns us, I think, to the findings of your study. And if we could just go there, you looked at patient characteristics. Who is using biosimilars? What can you tell me about what types of patients you saw in your study were either more likely or less likely to use biosimilars relative to biologics?
So our study, like just recently published in Health Affairs, we included 10 years patients who are covered by Medicare Advantage plan and commercial plan, and we found that the patients were less likely to initiate biosimilars if they were younger than 18 years old. It is possible for this finding is that lower biosimilar initiation in pediatric populations. Because those pediatric indications probably carved out of their labels because of ongoing patents protected by the originators' biologic products or FDA-granted exclusivity. And we also found that some of the products or some of the drugs, their pediatric dosage forms may just be unavailable for biosimilars, but it is available for biologic products because it is like a way for biologic products to distinguish their advantages of their products compared to the biosimilars when the biosimilar is on the market. So biologic product manufacturers put more efforts on doing additional clinical trials to show their efficacy for pediatric patients, to show their safety and efficacy.
So there's a real difference here with pediatrics. We also, I'd also like to talk to you about some of the other sources of variation in biosimilar initiation. We'll cover some of those additional topics after we take a short break. And we're back. I'm here with Dr. Dongzhe Hong, who has published a paper with co-authors in Health Affairs discussing uptake of biosimilars and looking at the characteristics of both the patients and the providers who are the prescribers who are more or less likely to call upon these biosimilars. But before the break, we discussed the lower rates of biosimilar use in the pediatric population. Interestingly, your study found some geographic variation. We've always been interested, I think, in geographic variation in healthcare. So these patterns, lead to more questions sometimes than answers. But if you could you say a little bit about what geographic variation you observed, and to the extent you have hypotheses about why? I'd love to hear that as well.
Yeah, sure, of course. So, when we start doing this project, we just want to see whether there's a region differences for the biosimilar initiation, and finally we decided that why not look at state difference, because there's a lot of state-by-state variations in clinical practices, behaviors, and even regulations and laws. So in our study, as we provided in the Exhibit 4, the graph shows that there's a geographic differences between states. And this could be attributed to several factors, even though we haven't tested yet. For example, physicians in some states may be more inclined to adopt new treatment options like biosimilars due to differences in training, familiarities, or local prescribing guidelines. And another important factor could be the regulatory environment surrounding biosimilar substitutions, which really varies by state. Some states have more favorable regulations that facilitate the substitution of biosimilars for their reference products, but some of states, they didn't mention that at all. So our study is more to present this fact to our audience, and we really appreciate future studies could dive deeper into these variations to better understand the reason underlying this fact. And by examining how state policies, healthcare infrastructures, provider educations, and biosimilar substitution regulations, how they could come together influence the biosimilar adoption.
Yeah, I think it'll be really interesting to see how that plays out, because of course we have practice patterns that we know are regional, but then as you note, the regulatory environment is also different, and how those interact with each other could be quite consequential here. You also found differences depending on the site of care. I wonder if you could explain, first of all, what you mean by that, but then say a little bit about what differences you did see, and again, your hypotheses about why they might arise.
Yes. So in terms of the site of care, we are more focusing on the provider's characteristics. So our major finding is that we found patients were less likely to initiate a biosimilar if the drug was prescribed by a specialist compared to a a primary care physician or administered in a hospital outpatient facility compared to a physician's office. We did a literature review and referring to other studies and found some possible explanations for this finding is that the biosimilar initiation or the lower biosimilar initiation in office settings compared with hospital outpatient settings may be partially attributed to different drug pricing programs and reimbursement policies between hospitals and physician offices. For example, provider organizations can be financially incentivized to use higher priced drugs to maximize revenue, particularly if they are able to purchase them at discount prices through the 340B program, and which to them, even the lower cost of a biosimilars doesn't make any sense to them.
Yes, this is such an area ripe for additional analysis and policy work, where we see that distortions in the financial incentives at the provider level can get in the way of a broader societal benefit that you might have from higher rates of generic prescribing, or in this instance, biosimilars. And so another area that I know more work could be done. Well, as you described earlier, and as I mentioned very briefly at the outset, the data you gave regarding rates of the rates of adoption of biosimilars relative to generics being generic drugs being much slower does suggest that there is room to do better. And I have, we've put a lot of work in this country into trying to make the generics market work. Based not just on this study, but your broader analysis of pharmaceutical markets, I wonder if you could say something about the policies that might achieve a higher rate of biosimilar uptake in the United States.
Yeah, it's really a great question. So biosimilar uptake in the U.S. is really lower than what we would like to be. And I think there's a very excellent example that for our generic market, how it is going to go and how to help our patients to better get access to the treatment that they need. So of course, there's a room that we could improve this factor, and probably we may focus on several key areas. So first of all, that came into my mind is to enhance the education for both patients and physicians about the biosimilars. So we should educate both of them about the safety and effectiveness of biosimilars to help increase comfort and confidence in using these medications. This is very important, and this is something we learned from the other project that patients and physicians' perspectives to biosimilar products. And the other thing would be payer policies reform or payer policy changes, since payers play a really significant role in the adoption of biosimilars. For example, implementing formulary management strategies that prioritize biosimilars could be a powerful way to increase their uptake. Specifically, payers could use step therapy where patients must try a biosimilar before being approved for a more expensive reference biologics, or they could offer lower copayments for biosimilars or ensure biosimilars the preferred option when appropriate to the specific disease or conditions. So this strategy together can make biosimilars more attractive to both patients and providers. And probably something related to regulations or laws as well. Since the Biologics Price Competition and Innovation Act of 2009 established a pathway for FDA-approved biosimilars, but to enhance the biosimilar adoption, future policies may consider implementing pilot programs, for example, the so-called fast-track designations for biosimilars, targeting those high-need therapeutic areas, thereby expediting review times or addressing the extensive patent protections associated with biological products, especially issued after their primary patent expiration and reducing the exclusivity period for branded biologic products from, for example, from 12 years to 7 years, which is same as the generic drugs. And this could reduce market exclusivity periods and encourage competition afterwards. And I may also think about the future studies direction about those biosimilar uptake is that since our study only focus on physician-administered biosimilars, so future studies might further explore the adoption patterns for self-administered biologic products, for example, insulin, to better understand the broader implication of biosimilar adoption across different medication types and different disease areas.
Well, what I enjoy about talking to you about this work is that we've made a very intentional effort and changed the legal regime around generic drugs to promote their use, and we're a little behind when it comes to biologics, but many of the same issues arise, and so with good data to show us the comparison between our ability to gain adoption of biosimilars relative to our ability to gain adoption of generics, there's sort of a roadmap here. We know what the issues are, and the evidence can point us to possibilities for change that will yield greater use. And I also appreciate your last comment about the depth of the study, that going to self-administered raises a different set of issues. Obviously, you discussed here prescriber characteristics, and as the role of the patient is higher for self-administered, presumably some of those education awareness kinds of campaigns that you mentioned at the outset could have a larger effect. So this feels like an area ripe for both additional analysis and to enable us to use that analysis to improve policy. And that's, of course, what we like to do here at Health Affairs. So Dr. Hong, thank you so much for doing the work and writing the paper and explaining it and being my guest today on Health Podyssey.
Yeah, thank you very much for inviting me in, and thank you very much for this opportunity. Yeah, looking forward to future collaboration. Thank you.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about Health Podyssey.